अभी Good morning to all the participants. Am I audible? Can somebody confirm? Dr.
Yes,
Geetika,
ma'am.
can you let me know if I am audible?
Yes, ma'am.
Dr. Hemlata, yes. Are you able to hear me?
Yes, ma'am. Yes, ma'am.
All right, I am not able to hear you. इसका थोड़ा सा वॉल्यूम बढ़ा दीजिए स्पीकर का. डिले है ना. Please confirm.
Hello.
Yes. So you are able to hear me now?
Yes, ma'am.
All right, thank you. So we have three participants as of now, Dr. Geetika, Dr. Swati, Dr. Pooja and Dr. Hemlata. We have four now. A very warm welcome to all of you to the
Thank you, ma'am.
pre-conference workshop of APICON at Baldev Singh Sleep Laboratory. And I would like to thank you for your interest in overnight polysomnography. And at the outset, I would like to say that I would like this to be an interactive workshop. So don't let this be a one-way communication. So I would like that you should participate. If you have any doubts, you should ask, and you should equally participate in the workshop, because this is a workshop. This is not just a lecture. So please feel free to unmute yourselves and interact with us at any moment. I would like to introduce you first of all to the team that we have at this end at Baldev Singh Sleep Laboratory. Can we have you here? Uh, so this is Rishabh Soni. He's MSc student in our lab, and Dr. Biswa Gaurav. He's the MD student working in our lab. So both of them will be joining us today in conducting this workshop. Thank you. So we will start in the interest of time. It is already 9:35. First of all, the screen is visible to you?
Yes, ma'am.
All right. So first of all, I would like to tell you something about our lab and the achievements of Baldev Singh Sleep Laboratory. A little bit about the history of the lab. Just a moment while I fix some glitches here. So the lab was established in 1965, and Professor Baldev Singh had established this. He was also known as grandfather neuron or papa neuron, and Professor B.K. Anand. Both of them had established the laboratory in 1965 at AIIMS New Delhi in the Department of Physiology. Uh, I'll be telling you about some of the research that has been done in the lab. So initially, there were Dr. T. Desi Raju had done some studies, and Dr. Baldev Singh did some studies where in animals primarily, where they caused lesions in the area lateral to the trigeminal nucleus, which abolished ipsilateral eye movement selectively during paradoxical sleep and not during the alert state. Then there were also split brain studies in cats and monkeys which were done during different sleep stages. So initially the lab was set up as animal as well as human sleep lab. So this is the only lab of the country where both animal studies and human studies are done. Then Dr. B.K. Anand and Dr. Baldev Singh investigated many renowned yogis during sleep wake and meditation in the 60s. In the late 1960s, Mauro Mancia from Milan, he joined the department to study sleep physiology in monkeys. He was a disciple of Giuseppe Moruzzi, the co-discoverer of ascending reticular activating system. So you must have come across in the literature that you have read that Moruzzi and Mogun were they have actually discovered the ascending reticular activating system and their role in the sleep wake cycle. When they did the study here, they studied the RAS in conscious monkeys with split brainstem, which showed that desynchronized sleep was almost abolished and EEG synchronization was strongly reduced in these monkeys. Professor V. Mohan Kumar joined the Department of Physiology in December 1968, and he joined the sleep lab and he worked on ventromedial hypothalamic neurons on stimulation of rostral and caudal brain stem reticular formation. He worked with Dr. Sikdar. Then they also published a paper on caudal brain stem. It can produce EEG synchronization not only during low frequency stimulation but also during high frequency stimulation. Some of the other studies that have been done are preoptic neuronal activity during EEG alterations. So there was also single unit neuronal recording which was being done in the lab at that time, and using stereotaxy and three-dimensional stereotaxy, various areas of the brain were localized, and the impact of lesion and stimulation of these areas on sleep-wake cycle was studied. Changes in sleep wakefulness on application of adrenergic agonists and antagonists in the preoptic area. So the preoptic area and the hypothalamic area was some of the areas that the scientists working here, the doctors working here have concentrated on. Then midline thalamic neurons and their responsiveness to brainstem and hypothalamic inputs was done here. The first neural transplantation study in the country was done in our lab in 1996. Dr. Sunita and Dr. Joshi John carried out the studies to recover sleep after transplantation of fetal tissue in the preoptic area lesioned rat. Then simultaneous electrophysiological recording of sleep and functional MRI in rats showed the activation of medial preoptic area during sleep. This was published by Khubchandani et al. In 2006. And there were various students of Dr. Mohan Kumar who are now prominent scientists throughout the world. Some of them are Dr. Sujit Sikdar, Dr. Subimal Datta. They are working in the United States. Dr. Birendra B.N. Malik, who is in JNU. Professor H.N. Malik, who was heading this lab and retired 2 years back. Dr. Joshi John and Dr. Thomas Thanikal. Professor H.N. Malik was the one who next took care of the lab, and he worked on the role of preoptic area and medial septum, integrating sleep wakefulness with male sexual behavior and thermoregulation. Dr. Sri Vidya and Dr. Kamlesh Gulia worked on the role of septum on sleep and neural mechanisms of penile erection during REM sleep. Functional MRI shows activation of medial preoptic area during sleep. This was published in 2005. Then Dr. Mahesh and Mahesh Kaushik and Dr. Dipendra, who are now working in universities in Japan. They were PhD students in the lab. They worked on the role of lateral preoptic area on sleep thermal preference. Dr. Karuna Datta was instrumental in setting up of the human sleep lab in 2014. She was a PhD student here, and she's a colonel in army, working in AFMC right now. Trina Sen Gupta worked extensively on inotropic glutamate receptors in the medial preoptic area on body temperature. So you can see the various techniques that were used over here, starting from stereotaxy to single neuronal recording, and subsequently in 2014, the human sleep lab was established. These are some of the papers, recent papers. Muscle temperature least altered during total sleep deprivation in rats, and acute sleep deprivation elevates brain and body temperature in rats. Then these are some of the papers from Yoga Nidra and mediodorsal thalamic nuclei in rats. Yoga Nidra has been done in the human sleep lab, and mediodorsal thalamic nuclei work has been done in animals, of course. And this is our most recent publication on electroencephalographic and electromyographic events during spontaneous and final arousal from sleep, study of the sequence of appearance and significance. And there have been more than 200 publications from Baldev Singh Sleep Laboratory. They can be accessed at this link that has been provided. So with this small introduction about the lab, I will go on to the topic of our discussion today of the workshop, that is overnight polysomnography. So I can see that Dr. Sankalp is also here. Welcome, Dr. Sankalp. We have some more participants. Can you just put the next PowerPoint, please? So before I begin with the briefing, let me just tell you about the structure of the workshop, how we will proceed. So I have just introduced the lab. After this, I will be taking a very brief introduction on the principles of polysomnography to give you an idea of what polysomnography is and what are the basic principles for conduct of polysomnography, what are the electrodes, what are the electronics, and what are the parameters that we see, what are the indications, etc. And then we will move on after a break from 10:30 to 11 o'clock. We will move on to, we will demonstrate how to conduct polysomnography on a subject. So that will be live. So 11 to 1 we will have live demonstration of polysomnography. So in the meanwhile, if I can just have a round of introduction, maybe you can unmute yourselves and you can tell me your background, and if you have done any work in sleep, or if you are keen on doing any sleep, any work in sleep in the near future. I mean, it's fine even if you have not planned right now. So can we have Dr. Hemlata? Maybe you can introduce yourself.
Yes, ma'am. Myself, Dr. Hemlata Gupta, Associate Professor in ESIC Medical College, Alwar, Rajasthan. I only in previous I job in the Chhattisgarh, Raigad Medical College, Lakhiram Agarwal Medical College. I saw only EEG, electroencephalography, done there in the Raigad Medical College. I personally I did not do anything with sleep study, but I
Okay.
want future if you allow, if you support me.
Certainly, certainly. Thank you very much for your interest, Dr. Hemlata. Dr. Geetika,
Good morning, ma'am.
good
I'm
morning.
from Jammu. I'm professor and head Department of Physiology in ESCOMS.
Okay.
So right now we don't have a good infrastructure, but I just want to go through this so that, in future, if we have it, so we'll perform the test.
Yes, yes, that's excellent. That's excellent. Welcome, Dr.
Thank you.
Geetika.
Thank you, ma'am.
Dr.
Thank you,
Piyush,
ma'am.
Dr. Piyush,
Good morning, ma'am.
good morning. Yes.
Myself, Dr. Piyush, ma'am, PG student, ESIC Medical College, Faridabad, ma'am.
Okay, which department?
Ma'am, MD Pediatrics, ma'am.
Pediatrics. All right. That's great.
Okay.
So, do you
It's
do
a topic
polysomnography?
of interest for me, ma'am, personally. That's why I'm joining this.
Okay, that's wonderful. That's wonderful. Welcome, Dr. Piyush. Dr. Swati,
Thank you, ma'am.
Morning, ma'am.
good morning.
Uh, I'm Dr. Swati from. I'm doing PG in physiology
From,
in Maulana Azad Medical College.
okay. Okay, that's great.
I've done
Uh,
I've done my UG from AIIMS Rishikesh.
okay. Welcome, Dr. Swati. I think
Thank you, ma'am.
Dr. Sanket. Dr. Sanket.
Good morning, everyone. I am Dr. Sanket, PG student from ESIC Medical College, Faridabad.
Okay. Which
Uh,
specialty?
Ma'am, transfusion medicine, immunohematology.
All right, all right. So you have some interest in sleep physiology?
Yes,
Sleep.
ma'am. I am like very keen to know the sleep physiology.
Okay, that's great. Welcome, Dr.
That's
Sanket.
right.
Jatin,
Good morning, ma'am.
good morning,
Hello.
Jatin. Yes.
Myself, Jatin, ma'am. I'm doing MD Radiology in ESIC Medical College,
Okay.
first year resident.
All right.
I was interested in how this all process works, and so I joined this conference.
Welcome, Dr. Jatin. We
Uh,
we do have a collaborative project with the Department of Radiology here. We are doing MRI
Yes,
in
yes,
patients,
ma'am.
to in one of our projects. So we do have collaborations with radiology. We are glad to have a radiologist on board. So is there anyone else I
Thank
have
you.
left out? Okay, I think Dr. Sankalp is here from the organizing team, coordinating things at the back end. Probably can't hear me. All right, I think we'll proceed. Dr. Neha, you want to say something?
Ma'am, I'm Dr. Neha. I'm from ESIC, first year PG student, Department of IHBT.
Which department is this? Sorry.
Immunohematology and blood transfusion.
All right. Most welcome, Dr. Neha. Sorry, I think I had
Thank you, ma'am.
left you out. So now that we have all the
Yes,
introductions,
ma'am.
I will start with the briefing. All right, and we will take a break. I think from 10:30 to 11 o'clock, we'll have a short break because there are some participants, offline participants, and for the online participants also, we'll just take a short break. After that, we will start with the hookup procedures. So I will start a little bit with the history because without going into the history of our topic of interest, nothing is ever complete. So, the initial beginnings about the areas which affect sleep was made by Von Economo in from 1917 to 1928 when there was an epidemic of influenza, and he did some autopsies in those who had excessive sleep and those who had insomnia. And he found that there were lesions in the anterior portion of the hypothalamus in those who had insomnia, and there were lesions in the posterior portion of the hypothalamus in those who were suffering from hypersomnia. And the first person to record the electrical activities from brain was Hans Berger, who in 1924 first recorded, put some electrodes on the skull, and he recorded the electrical activity. Subsequently, Loomis and Harvey in the 1930s, they actually discovered the K complex, and they studied the changing cortical potentials during sleep. They were the first ones who attempted a classification of the sleep waveforms. So they classified the waveforms from A to E, and even though at that time they had not actually looked at REM sleep, but they did try to classify the waveforms into 5 types. Then Bremer in 1935 gave a theory that sleep is a passive process, which today we know that it is not a passive process, it is actually an active process. Moruzzi and Mogun in 1949 discovered the ascending reticular activating system. I have mentioned Moruzzi, he did visit our lab in the 1960s. Then Kleitman and Aserinsky. This was, I think, one of the most fundamental and landmark discoveries in the history of sleep, where they discovered the occurrence of rapid eye movement sleep. So up until now, whole night recordings were not done actually in humans, and this was the time when they started recording whole night sleep. And then they realize that during sleep there are certain stages during which they have activity, brain activity, which is very similar to wake. So it looks like from the brain activity it appears that the person is awake, but actually the muscle tone is so low that the person is lying very still. So this was the time when rapid eye movement stage was discovered, and Dement and Kleitman in 1957 they associated REM sleep with dreaming, and for a very long time it was thought that dreaming is exclusively associated with REM sleep. So these terms were used together, and it was assumed that dreaming occurs only during REM sleep, whereas dreams have now been recorded to during non-REM sleep also, recorded in the sense that it has been found by various methods that even during non-REM sleep there is dreaming. Then Michael Juve in 1965 gave the term paradoxical sleep to REM sleep. Uh, can anyone tell me why it is called paradoxical sleep? Why is it called paradoxical sleep?
Para means, ma'am, this is opposite of its name.
Why so? Why so? That is the meaning of paradoxical. But why is REM sleep known as
There is
paradoxical?
the rapid eye movement. Rapid eye movement is the occurred why the sleep is deep. This is the
Because
Yes.
deep
ma'am,
sleep.
because I think
Rapid eye movement have a patient, a person have deep sleep, and then the paradoxical, then rapid eye movement is also there. So how this is possible? The movements is more and the sleep is deep.
Yes. Even though the person is immobile because of the very low muscle tone, yet the brain activity resembles the wake state. So that is why it is known as a paradoxical sleep. All right. So let me just tell you what the normal sleep looks like. This is the sleep pattern from the newborn to the adult stage. So if you look at the top panel, let me just get a pointer here. So here you can see in the top panel, this is the sleep pattern of a newborn, and the troughs here are the sleep periods, and the crests are the wake periods. So and on the x-axis is 6 p.m. to 6 p.m. So 24 hours on the x-axis. So what you can see in the first one, where the newborn is sleeping, is that the sleep cycle is polycyclic. They wake up and they sleep many times during the night. Then when they reach 1 year of age, the infant will sleep, will have a longer sleep period during the night, yet they will have 2 episodes of napping during the daytime. By the time they reach 4 years, the nap is reduced to once a day, and by once they come to 10 years, there are no daytime naps, and the nighttime sleep is considerably longer, it's about 10 hours. Then in the adults, the sleep is finally set to 6 to 8 hours during the night with no daytime napping. Of course, daytime napping is voluntary and um, can be taken by anyone. So these are the stages of sleep. as currently followed as per the classification by American Academy of Sleep Medicine. So American Academy of Sleep Medicine is the authority which is giving the recommendations regarding the classification of sleep stages, how to recognize the different stages, what are the things which should be done in polysomnography. It is one of the most common recommendations followed throughout the world, and this is what we follow in our lab. So currently the stages that are recognized are stage wake, N1 to N3, and stage R. So non-REM sleep is divided into 3 stages. So why I am stressing upon currently is because in 2007, till 2007, there were 4 stages of non-REM which were recognized from 1 to 4. But in 2007, 3 and 4 were clubbed because it was found that feature wise and characteristics wise there was not much difference between 3 and 4, and there was some confusion in classification and staging of sleep. So now we have 3 stages of non-REM, N1 to N2, N3, and stage R. So this slide is showing you the structure of sleep. If you look at the top panel, this is showing in children, the middle one is in young adults, and the lower one is in the elderly. So let me just explain what happens in young adults, then I will show you the differences between children and the elderly from the young adults. So in the young adult, you can see on the y-axis, the top one is awake, then REM, and then non-REM stages from 1 to 4. So pardon this stage 3 and 4, this is taken from a source which was published uh, before the stages were clubbed. So in the literature, when you go around, when you read the literature, you will find that a lot of them still have mention of stages 3 and 4. A lot of papers will have the mention because the transition was made only in 2007. So here what you see is that once the person enters into sleep, they are going to enter stage N1, then N2, 3, and then they are coming to REM. So this cycle of going from N1 to N3 and then REM is known as one sleep cycle. So there are around 1, 2, 3, 4, 5, 4 to 5 normal sleep cycles during normal sleep in the night. And if you look at these interruptions, these are 2 episodes of wakefulness. So a normal person, healthy person, can have around 2 episodes of wakefulness during the night. And if you look at N3, N3 and 4, the deeper stages of sleep are happening more during the first half of the night, and the REM stage is the red one here. This the duration of the REM sleep goes on increasing as the night progresses, and the longest duration will be just before wakefulness. So if you contrast this with children on the top panel, I hope all of you are following me.
Yes, ma'am.
All right.
Yes.
All right. So in children, what you see is that they have they also have 4 to 5 sleep cycles during the night, but they have a longer time, more time that they spend in stage 3. Okay, this duration is longer, so they have a deeper sleep than adults, and they have less number of wakefulness episodes during the night. There is only one wakefulness here. So coming to the elderly now, if you look at this sleep pattern, so what is most remarkable about this is that there is very less time which is spent in stage 3. So the time spent in deep sleep reduces as with age, and the number of episodes of wakefulness, if you see here, there are 8 to 9 episodes of wakefulness. So they have fragmented sleep. Elderly have fragmented sleep, and the amount of time they spend in REM is also reduced. So this is not pathological, this is physiological, it is part of the aging process. So literature has also spoken about sleep from the very beginning, from Shakespeare to Van Gogh, from Charles Dickens to Disney screenwriters. They have all talked about sleep in literature. Coming to our topic of interest today, that is testing of sleep. So how do we test sleep of a person, whether it's a patient or if it's a normal person? So some of the procedures are sleep center based, like there is in-lab diagnostic polysomnography. These are pictures from our laboratory. This is the patient area, and this on the right side what you can see is our software. We will be showing you the software and also the various stages of sleep. There are some other procedures which can be done in the lab, that is in lab positive airway pressure polysomnography, where those who have obstructive sleep apnea are given continuous positive airway pressure CPAP. Then there is multiple sleep latency testing and maintenance of wakefulness testing. So today we will not be going into MSLT and MWT, we will only be focusing on polysomnography. There are some ambulatory procedures also which are used to test sleep. For example, home sleep apnea testing, in which there is an overnight unattended screening test which monitors breathing and oxygen saturation. So there are equipments which will monitor the breathing and they will monitor the oxygen saturation. Their main purpose is to diagnose obstructive sleep apnea because it is one of the most common disorders, and instead of calling everyone to the lab, which is a very expensive procedure in the private, and it is also a very labor intensive procedure, the subject as well as an attendant and the technician have to be there overnight in the lab. So for screening, home sleep apnea testing is quite useful. Then actigraphy is another way in which sleep and wake cycles can be tested. The actigraphy devices are the watches which are based on accelerometers and which are worn on the wrist, which basically use fine motor movement and light exposure monitoring across multiple days, and they are used for the diagnosis of insomnia and circadian rhythm disorders. Now since polysomnography is a recording which is done only on one night, it is not recommended for diagnosing circadian rhythm sleep disorders, or where we need data from multiple nights. For example, if a person says I have insomnia, I am not able to sleep properly, it does not mean it is an indication for polysomnography. We would like them to either make a record of their sleep hours using a sleep diary first, and or we can give them an actigraphy which gives us a fair idea of their sleep wake patterns over a week or so. So even though they are not gold standard, the gold standard investigation is only polysomnography. So what happens in polysomnography? The definition was given by Holland, Dement and Renault in 1974. They were based in Stanford, in the sleep lab in Stanford at that time, and they have defined it as recording, analysis and interpretation of multiple simultaneous physiological parameters. So what you find missing in this definition is sleep. The definition does not mention sleep, because polysomnography as an investigation can be used to investigate a number of phenomena, physiological phenomena. We will tell you what all can be recorded, and it happens to be an excellent tool for recording sleep, and that is why it is used extensively for the record of sleep. So this is what the interface, the software looks like when we are recording polysomnography. The top two channels are showing the electroculograms, then the next 6 are the EEG, then we have the EMG, the ECG, and the leg movements, pressure sensors, flow thermistor. It's all right if you are not able to understand right now. This is just a representative diagram. We will be talking at length about all these, and then you will be able to make out better, hopefully, what these parameters are. So these are the parameters that are recorded in polysomnography as per AASM criteria. So there are some parameters which are recommended. Recommended means they are a must for doing polysomnography, and there are some which are optional parameters. So on the left side in this panel are the are the recommended parameters, that is EEG, electroencephalogram, electrooculogram, chin EMG, respiratory channels, snore sensor, ECG, position sensor, leg EMG, oximetry, blood pressure and videography. So a position sensor helps to know what is the position of the subject throughout the night, whether they are supine or they are left lateral or right lateral. And then leg EMG will tell us about whether if there are excessive leg movements, for example in restless leg syndrome or periodic leg movement syndrome. Then blood pressure is actually not essential. It is some of the equipments have the option of doing blood pressure. Not all equipments have this. Then we have it available in our equipment. Then videography has been labeled as an essential parameter for polysomnography. Optional parameters are core body temperature, incident light and intensity, and pressure and pH at various esophageal levels. So these may be used for research or for other purposes, but they are not essential parameters for doing polysomnography. So this is what is a schematic overview of the automated sleep scoring system. So let me take you through this step by step. So if you look here, the various electrodes are placed when doing polysomnography at various places. So these in the second panel here, all the electrodes are mentioned, the parameters which I have already told you. And then the video is recorded over here. Video is being input, the personal computer is getting the input for that. Then there is a microphone which will record the not only the snore sounds, but also if the patient wants to say something during the night, he wants help, he wants to call out to the technician, then a microphone is placed so that the recording technician who is sitting in the other room is able to hear and who can come at any time if assistance is required. Then the EEG and EOG are fed into the preamplifier, body position through the transducer, ECG, blood pressure amplifiers. So all these amplifiers and the signals are fed into the head box and they go into the central panel where various settings, filters will be applied, that is gain and offset setting, and what channels we want. We can change the channels as per the requirement. They will be done by the personal computer, which is fed with a time code. And then this will show us now that we have softwares. Earlier there was a recording on paper, like EEG was done, polysomnography was also done like that, and there were meters and meters of paper record which was seen, which was recorded throughout the night. But now we have the software, so we can look at each the recordings on the screen itself. So and then this will go to the computer which has a peripheral devices, and we can look at the display of all the signals, and then we go about doing what is known as the sleep scoring, that is dividing the sleep into various stages. We'll be talking about that towards the end. So let me tell you about the levels of sleep studies. There are 4 levels of sleep studies which can be done. Level 1 studies are where all the channels which I have mentioned previously are recorded, and it is attended by one sleep technician throughout the night. Level 2 is the first one is in lab, so it is usually done in the lab where there is video recording also. Level 2 is where there are all the channels except the video. It is unattended, it is at home, a portable machine is used, and the technician or the recording person can visit the home of the patient. They are going to set up everything and then they will leave. So the problem here, the advantage is that the patient is in a familiar environment, they are at home, and they are more likely to have better comfort levels and better sleep if they are at home. The disadvantage is, and better compliance. The disadvantage is that if it is unattended, then there is a chance of some of the electrodes coming out during the night, and there may be loss of data. So we have to weigh the pros and cons, and as per the requirements, the level of sleep study can be chosen. Then there is a level 3 study in which there are only 4 channels, that is respiratory effort by chest or abdominal movements, oxygen saturation by pulse oximetry, airflow, and ECG. So if you look here, the effort will tell whether the apnea is central or it is obstructive. If there is a respiratory effort, then the apnea is obstructive. If there is no effort, there are no chest and abdominal movements, then the apnea is a central apnea because there are no chest or abdominal movements. Then oxygen saturation pulse oximetry helps us to mark the times when there are apneas and when there are hypopneas. So this is used basically for the diagnosis of obstructive sleep apnea. Level 4 studies, only one or two channels maximum are used, which are oxygen saturation or airflow. They are used in patients who are not willing for a higher level of study or in children for screening of apnea basically. So let me take you through the basic principles of recording. So what is EEG? EEG records the local potentials beneath the electrode or alterations in neuronal activity in other parts of the cortex, and these are not the action potentials, and only the activity from lamina 1 to 3 are recorded. So if you look at this diagram over here of the cortex, there are 6 layers, and from the 6 layers it is only the top 3 layers from which the electrical activity will reach the electrode which is placed here on the top. Okay, and mainly it is the pyramidal cells from which the activity is being recorded.
Pardon, ma'am.
Yes.
Pardon, ma'am. Ma'am, this is not action potential. Potential. So what is this? This is local potential.
These are actually what you see are dendritic potentials and the local potentials which are recorded from the neurons. These are not action
This is not.
potentials. No, I will show you in the next diagram that what all is recorded from here, and it is in microvolts, so the amplitude is very low. So we need to amplify it for visualization, and we need to filter the artifacts from EEG. Otherwise, it will be very difficult to make out the waveforms. And the number of neurons which come under one EEG curve are around 5,000. I don't have that diagram here, but it is I had one diagram where it was showing that it is actually the, because there are so many dendrites and the neurons which are there just under the electrode. So all the potentials which are getting developed over there, the local potentials, the EPSPs, the IPSPs, all of them will be picked up by the electrode, by each electrode. So it is the sum of these 5,000 neurons which are there under one EEG cup which is being picked up by these EEG electrodes. So these are some of the EEG waves that are found during sleep and wakefulness. The top panel is the beta waves, then the alpha waves, theta, and very particular of N2 stage are the sleep spindles and the K complexes. And then comes the delta wave. So I will be defining all these with the frequencies in the subsequent slides. So what are these? The electrodes are either silver or gold plated electrodes, and why gold plating is used? Because the electric potentials of these metals are optimal for recording of the cortical electrical activity. They have minimal signal drift, so if there is a change in the potentials, they will not show a drift for a long time. They will very faithfully and regularly follow the changes that are happening in the voltage. They have a long time constant, and they have the optimal electrode resistance. I will just come to resistance. Electrolyte paste we are going to apply that contains the chloride ions. That is a layer of electrical charges in the electrolyte paste. It helps to increase the conductivity and reduce the resistance to recording. So whenever we are recording from the skin, there are some sources of resistance which we don't want there. And what are the sources of resistance? One is the internal resistance from the internal activity of the cortex, then resistance from the dura mater, cranium and scalp, and then the resistance within the amplifier. So we cannot remove the internal resistance, but we can reduce the resistance between the skin and the electrode. So for that we use the electrolyte paste to increase the conductance, and also we prepare the skin, we prep the skin, we clean it, we abrade it a bit, all to reduce the resistance and so that we can get good signals. So ideally the resistance should be less than 5 kilo ohms. So this is the golden number that we look for in polysomnography. Our software will provide the resistance of the electrodes the moment we start the recording. So just what is synchronization and desynchronization? If you look here at the EEG electrode which is placed on top of the scalp, it is picking up all the electrical activities from these pyramidal cells. Okay. So if the all the signals which are coming over here in the right panel, if you see here, if the waves are not in synchrony, okay, their crests and troughs are not matched, then the signal that we get is desynchronized. The lowest one is showing the sum of the electrical activity from all these 6 pyramidal neurons. So here in the top panel you see that this is a desynchronized activity. Is the laser pointer visible? Gaurav, is the laser pointer
Yes,
visible?
ma'am.
All right, thank you.
Yes, ma'am.
All right. And if there is a synchronization in all these pyramidal cells as it happens in N3 or the deep stages of sleep, then you find that the amplitude of the waves increases. This is known as synchronized. So when do we see desynchronized waves of EEG? In which stages? Anyone? Which stages do you see desynchronized activity? What happens in wakefulness? Is it synchronized or desynchronized? Can we have responses from some of the participants?
Synchronized.
It is okay. What happens in deep
Synchronized.
sleep?
Wakefulness, ma'am, wakefulness is desynchronization?
Yes. Yes, absolutely. Wakefulness is
Yeah.
desynchronized and
And
REM is also
synchronization is sleep. Yeah.
sleep, only non-REM sleep. Non-REM
Yeah.
sleep has synchronized, REM sleep has desynchronization. Okay, so desynchronization is present in wakefulness and in REM sleep. So this is the 1020 electrode placement system. I think we can cover this during the workshop, so I'll not be spending time on this. These are some of the montages. This will also be covered there. So what is the basis of recording the electrooculography? So EOG is the recording of the eye movements. And how is it recorded? Just look at the lower panel first. One electrode on the left side is placed below and to the left 1 centimeter outside and 1 centimeter below the lateral canthus. The other electrode is placed 1 centimeter outside and above the right lateral canthus. Okay, and they are connected to the M2, that is the mastoid on the right side. And this is how the eye movements are recorded. What is the basis? The basis is that the cornea is positively charged with respect to the retina. So it forms a dipole. And if this is the recording electrode on one side, and if the eye is moving towards the electrode, then there will be a positive deflection. Okay, and if it is going away from the electrode, then there will be a negative deflection. So this is the basis for electrooculography, and it helps us to pick up the rapid eye movements which help in the diagnosis of, in the basically recognition of the REM sleep, and also the movements during wake or when the patient is with eyes closed and they have slow rolling eye movements or they have reading eye movements. All these can be picked up. So EMG is, you all know, it is electrical potential generated by active muscle cells. It's used to monitor the general picture of muscle activation, and we use basically chin EMG for seeing the tone during sleep. We can take EMG from any other muscle group, but we prefer chin muscles because the maximum fall of tone occurs in the chin muscles during sleep, it has been seen, and that is why we prefer to see the EMG activity of chin muscles. But if you want to see the tone and say the chin muscles, the chin EEG electrodes are removed, then the leg EMG can also be taken for seeing the tone during sleep. Am I audible?
Yes, ma'am.
All right, there seems to be some internet connectivity. I just wanted to make sure that we are still together. All right, so the other thing that is recorded is the respiratory effort. So for this effort, this is the sensor, what it looks like, and it is put around the chest and the abdomen. Okay, the most accurate is esophageal manometry, but it is not used routinely. It is not recommended. The what is used is the using the principle of inductance plethysmography. There is a change in the cross-sectional area of the abdomen or thorax, which causes a change in the diameter of the transducer. And because of the change in the diameter of the transducer, there is a change in the inductance. So this is calibrated to a volume, and this provides qualitative and quantitative analysis of breath volume. So if we calibrate it to a volume, ordinarily in polysomnography, the volume is not calibrated. So what we get are actually only the qualitative readings. So what is OSA or obstructive sleep apnea, sleep related breathing disorder? This is one of the most common disorders, and it is seen in people who are obese and who have metabolic syndrome. They are usually hypertensive and middle-aged or above. It is seen more in males than in females. After menopause, the incidence is same amongst males and females. It is characterized by repetitive episodes of complete apnea or partial closure of the upper airway, which causes hypopnea during sleep. Airflow measurement is done with the use of these electrodes. This is a thermistor. So there are these two metal wires that you see over here and one at this end. So their basic principle is that they detect the temperature change on inspiration and expiration. This changes the conductance of the metal, and this shows us the flow. Okay, and um, this one is the nasal pressure transducer, in which there is a change in the pressure of the airways. There is a pressure transducer at the end of this, which will detect the pressure changes. And the use of these two is that the thermistor is more accurate in detecting apneas, that is complete cessation of breathing, and the pressure transducer is better for detecting the hypopneas, that is there is a partial reduction of breathing during this time. The gold standard is body plethysmography and pneumotachography, but it is not done in polysomnography. The other sensors are the snore sensor, which is a simple microphone which is placed on the neck of the patient, and during the night it will record any sounds that are made by the patient. If the patient is speaking, it is going to pick up the sounds. If they are snoring, it's going to pick up the sounds. Then ECG, what is used is a modified lead 2 ECG. It helps us to give the average heart rate, and we can also take out the highest heart rate. Then if there are any bradycardias or arrhythmias, they can be recorded throughout the night. Pulse oximetry, which is the most important component of polysomnography to diagnose obstructive sleep apnea, will give us the what is the principle? It it assesses the oxygen saturation of arterial blood by passage of two wavelengths. There is a spelling error here, sorry. 650 nanometers and 805 nanometers. So whatever is the saturation of hemoglobin, that is HbO2, based upon that, between the two sensors, the light is going to pass, and it will detect by calibration that what is the basically the oxygen saturation of the arterial blood. So what are the indications of polysomnography? As per the task force recommendations by American Academy of Sleep Medicine in 2017, the foremost indication for polysomnography is any sleep related breathing disorder, including obstructive sleep apnea, central sleep apnea syndrome, and Cheyne-Stokes respiration. Narcolepsy, sleep related seizure disorders, periodic limb movement disorders, and depression with insomnia. So if there is only insomnia, a person says I'm not able to sleep, then it is not an indication for polysomnography. If there is restless leg syndrome, that is some people have this unusual sensation in the feet, they have to keep moving their feet in order to sleep, that is not an indication for polysomnography. It's a clinical diagnosis, both insomnia and RLS. So, for continuous positive airway pressure, CPAP titration in patients who have sleep related breathing disorders. CPAP is the gold standard recommended treatment for obstructive sleep apnea, and it is not routinely indicated for any chronic lung disease, for restless leg syndrome, circadian rhythm sleep disorders, or for depression. This is the international classification of sleep disorders. This is the most recent one, that is the third one, and it classifies sleep disorders into these groups, although it is not under the purview of our workshop today because we are focusing on the technique. But I just want you to have this in your cognizance that these are some of the sleep related disorders: insomnia, sleep related breathing disorders, central disorders of hypersomnolence, circadian rhythm sleep wake disorders, parasomnias, sleep related movement disorders, and some other sleep disorders. So, coming to the stages of sleep, I will finish the talk in around 5 minutes, then we'll have a short break. So, the stages of sleep are divided into these, which I have already mentioned. What are the scoring rules? So, whenever we score a sleep study, then we follow certain rules. I think we are better off talking about the scoring rules once you have seen the polysomnography. I think you'll be able to understand better. So perhaps I will cover the scoring part after you have seen the um, polysomnography and you have an idea of where the electrodes are placed and how the sleep stages look like. So these are the various stages: N1, N2, N3, the rules and the events. I will take this up once we have finished with the workshop. So with this I will conclude the current session and we will go for a break and we will reassemble at 11 o'clock. So is that all right with the other participants?
Yes, ma'am.
Yes, so please be here sharp at 11 o'clock. We are going to start
Yes,
the hookup and we will start recording polysomnography at that time.
thank you.
Thank you everyone.
Thank you, ma'am.
Thank you. Stopped moving again. इसको हाँ it is moving now. It's moving now. It's fine. Yes, बंद कर दीजिए. Okay, no more.
Hello. 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 हाँ तो रही है. Hello. 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 1 2 3. Check. 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 Hello. Hello.
Can someone confirm? Or are the participants not back from the break? We are going to ask you to switch on your videos once, because we are going to take a screenshot at some point. Dr. Renu Sangwan, I think you are here. Are you here?
Yes, ma'am.
All right, all right. So you can hear me. That's good. All right. Thank you. We have put a questionnaire. Actually, this is a Google sheet which we have put in the chat. So I will request all of you to please click on this and fill in your particulars, because we have to give it back once the workshop finishes. Okay, so please click on this link. I hope you can see it in the chat box. Please fill up this sheet.
Here, ma'am. Link.
It is in the chat box. Shall I post it again? I'll post it again, all right. Is the link visible now?
Yes, ma'am.
Okay, please start filling it. So Dr. Piyush, you have already filled it up. That's good. Can we have the other participants filling it up as well, please? Have you done? You had tea? हाँ, क्या स्टार्ट करना है? यूट्यूब? हाँ, कर दीजिए, कर दीजिए. हाँ हाँ, अभी थोड़ा I'll take 10 मिनट का. So how many of you have finished filling up the sheet? Only 2 so far. 3, 4 are online. Okay. So I think what I'll oh, okay, fine. So those who have not filled up the Google Docs, please go there and fill it up quickly. Google Sheets. Are you able to see the slides? Can someone just confirm?
Yes, ma'am.
All right. So I will just briefly tell you about the stages of sleep. Okay. That how do we score a study? Whenever a sleep study is completed, then excuse me. Whenever a sleep study is completed, we look at the sleep study and we take 30-second epochs. An epoch is one duration of time period that is visible on the screen, and for each 30 seconds we will assign a stage to it. Is it N1, is it N2, or is it R, like that. So this is known as scoring. So slow wave activity is frequency from 0.5 to 2 hertz and peak to peak amplitude of more than 75 microvolts, and it is measured over the frontal regions. Then delta waves are 0 to 3.99, basically 0 to 4. 4 to 7 is theta, and alpha is 8 to 13, and beta waves are greater than 13 hertz. So in stage wake, what we see is an alpha rhythm. If the eyes are closed, we will see alpha rhythm, that is 8 to 14 hertz activity. It is mainly seen in the occipital area. Then there are eye blinks, reading eye movements which have a fast and then a slow horizontal component, and rapid eye movements can also be seen during wake. Then there are sinusoidal eye movements. This is what a wake epoch looks like. You can see alpha activity over here. Alpha activity is, when we get used to looking at the EEG, then we can see visually also that this is alpha activity. The other thing that you can do is you can simply choose 1 second duration time on the screen, and we can count the number of waves that are there. So if they are 8 to 14, that means they are alpha waves. So this is also a wake epoch that you can see here. Eye movements are visible in this, and there is alpha rhythm in the occipital areas, and this is a typical wake epoch. This is also similarly a wake stage. Then what happens when the person enters sleep? The first stage to happen is N1. In this there are slow eye movements which are conjugate reasonably regular sinusoidal eye movements with a duration of more than 500 milliseconds. And in this what we see is low amplitude mixed frequency activity. This is not as simple to alright, so this is not as simple to diagnose as is N2 and N3 because they are very typical. So the maximum inter-observer variability happens in the scoring of stage N1. Then another feature is vertex sharp waves, and N1 defines the sleep onset. So whenever there is N1 stage at the beginning of the sleep episode, we mark it as the sleep onset. So here if you look at this particular epoch, we are focusing only on the EEG right now. These are the alpha waves, and they are transitioning into low amplitude mixed frequency waves. After this red line, if you can make out, there is a transition. And this is also a typical N1 stage where you can see here these are the slow eye movements in the second half of the epoch, and low amplitude mixed frequency EEG waves. Stage N2 is very typical. It is defined by a K complex and the presence of sleep spindles. What is a K complex? It's a negative sharp wave which is followed by a positive component. Duration is more than 0.5 seconds, and it is maximum in the frontal derivation. Sleep spindle is a train of distinct waves with a frequency of 12 to 14 hertz duration, and which are duration is more than 0.5 seconds, and it is mostly seen in the central channels, that is CZ, C3, C4. So these green ones, they are the typical spindles. So the moment we find that spindles are present, then we call it as stage N2. And here if you look, this one is a K complex. In the middle there is a sharp negative deflection followed by a positive deflection. Here again you can see K complexes and sleep spindles. So we can say without any doubt that this is stage N2. Then stage N3 is very easy to recognize. It has slow wave activity, the frequency is the amplitude is very high, more than 75, and the frequency is very low, 0.5 to 2 hertz. So here you can see these huge waves. Okay, this is a result of synchronization. There are no eye movements over here in these channels, but you can see delta activity here, and the chin tone is higher. It is higher than REM, but it will be lower than wake. So this is again typical delta waves of N3 stage. Are you able to make out the delta waves? I will need a response from the participants. Are you able to make out the delta waves? Dr. Renu Sangwan has joined us. Yes, Dr. Sanket, Dr. Nikhil. Are the participants here with us?
Yes.
Yes, ma'am. Yes, we can see.
All right.
Yes, ma'am.
So please be responsive. Otherwise, it seems that I'm, just talking to a blank. So what happens in REM? In REM state, there is a low amplitude mixed frequency EEG. There is a very low chin EMG tone, and there are rapid eye movements which are seen. So here you can see the rapid eye movements. The top two channels are the eye channels. So you can see, and these are typical sawtooth waves for REM. So they are resembling actually wake stage, except for the tone. So chin EMG you can see here is flat. Tone is very low. Okay. And this is also typical REM stage where there are rapid eye movements here, sawtooth waves here, and you find that there is a very low tone. This is the chin EMG, the red one, and this is almost flat. So what are the events in a sleep study? Whenever we mention the events, we will mark the lights out. Lights out means starting of the sleep study. Then lights on. Lights on is done at the end of the sleep study. Total sleep time. Total sleep time is beginning of the sleep to the end of the sleep. Then total recording time. Recording time is different from sleep time because the person takes time to fall asleep. Okay, so this is lights out to lights on. Sleep latency is the lights out to the first epoch of any stage of sleep. So a person who takes a very long time to sleep will have a much longer sleep latency. REM latency is sleep onset to the first epoch of REM sleep in minutes. So if it is for example, in narcolepsy patients, they go directly into REM. So the REM latency will be only a few seconds or 1 or 2 minutes. So wake after sleep onset is the time spent by the person awake after they have fallen asleep. If they wake up in between, then we call that wake after sleep onset. It is calculated by total recording time minus sleep latency minus total sleep time. Then percent sleep efficiency is sleep time divided by the recording time into 100. Time in each stage is mentioned. The arousal index, that is number of arousals per hour, is mentioned. Periodic limb movement of sleep index, how many limb movements have been there per hour. And then the PLMS arousal index. Apnea hypopnea index is of importance to diagnose obstructive sleep apnea, and respiratory disturbance index is the number of respiratory event related arousal. These are those events which don't qualify as apnea or hypopnea, but they are causing a decrease in the breathing pattern. So flow and effort measurement, I have already told you, these are definitions of apnea and hypopnea. So I don't think we need to do these today. And this is a sample report. In a sample report, we will give the...
Ma'am,
Yes.
ma'am, can you please show the last slide, sleep apnea?
This one? This one?
No, ma'am. Yeah, ma'am.
Oh, you want the definition of apnea and hypopnea? Okay. So
Yeah, ma'am, just key how much. Yeah.
Sure. So as per American Academy of Sleep Medicine, apnea is recorded from the signal from the thermistor. Okay, so I told you there are two sensors for flow. One is the thermistor, which is based on temperature, and the other is the nasal pressure transducer, which is based on pressure. Okay, whenever these two criteria are met, then it is defined as apnea in a thermistor sensor. What are the two criteria? Drop in the peak signal excursion by more than 90% of the pre-event baseline, and the duration of this is more than 10 seconds. So this is the definition of apnea. Okay, so this is calculated by the software itself. That we have to feed the settings into the software, and it will recognize and it will mark it on the sleep study. Then what is the definition of hypopnea? Hypopnea is when there is a drop by more than 30% in the signal excursion and duration is more than 10 seconds. In addition, it has a criteria of oxygen desaturation of more than 3% from pre-event baseline. So difference between apnea and hypopnea is, one, the reduction in the signal, 90% reduction in apnea, 30% reduction in hypopnea. Other is duration is same, it should be more than 10 seconds. And in addition to this, in hypopnea there is a more than 3% oxygen desaturation. Oxygen desaturation criteria is not there for apnea. Alright. So now
Thank you, ma'am. Thank you, ma'am.
Sure. So these are the events that are mentioned on a sample sleep report. I have told you all these reports: number of awakening, stage shifts, what is the duration of each stage, what is the percentage of each with respect to the total sleep time, sleep period time, and then the what are the spontaneous arousals, what are the apneas, hypopneas, snoring, periodic limb movements, like that. All these are given in a sleep report. And these are the events by stage and by position. So stage wise also we can give the occurrence of obstructive and central apneas. Then we can also record the respiratory event related events based on the position also of the person, because sometimes they will have more events in the supine position. So it is a positional apnea, you know. So some patients may benefit by just telling them that you can sleep on the side. So that will lead to a reduction in the number of apneas that they have. Okay, so all these events have to be recorded by the technician: lights on, lights off, initiation of PAP, patient leaves the bed, position changes, technical difficulties. All of these have to be noted in the sleep study. And these are some of the references, some of the books, articles which you can refer to for getting more information on this. If you want, you can take a screenshot of this and you can keep this in your record. Thank you. That's all we have in the briefing. Now we'll move to the lab and we will start with the patient hookup. Before we go over there, I want that all of you should please fill up the Google sheet that I have shared. If you want, I can share the link again, because I think some people may have come back later. I would like a confirmation from everyone that they have filled the sheet, please. Can you please switch on your videos, everyone? We would like to take a screenshot for record purposes. Can I request the participants to please switch on the videos?
My camera is not working properly.
Okay, okay, whoever can. We need to take a screenshot with all the participants on. Can you also come? Where is Gaurav? You can also come here. Where is Gaurav? We are just taking a screenshot, so maybe both you can. All right. Can we have some more participants switching on the videos, please? Thank you, everyone. I'm just going to, is it recorded? Okay. So now you can please go ahead and fill up the Google document, the Google sheet, and by the time we'll shift the camera and everything to the lab. Thank you. Thank you, everyone.
Thank you, ma'am.
Shall we start? इसकी लैपटॉप की जरूरत तो नहीं है अंदर ना?
अंदर लैपटॉप चाहिए? तुम बैठे रहो ऐसे। So welcome to the part of the sleep study. I will be demonstrating how to prepare the subject for a sleep study and the biocalibration and and like all the necessary things that we need to do in the record. So the hookup, it essentially means the like the putting of all the necessary parameters that are needed to which are needed for a sleep study. So there are several parameters. I'll go step by step. Firstly, we will start with the EEG placement, the EEG electrode placement. So as you can see there, can you please move the camera? This is the 1020 system, which is also shown to you by the faculty. This is the standard electrode placement, which is recommended by the American Academy of Sleep Medicine. The electrodes that we need, the R montage consists of 6 channels: F3C3O1, F4C4O2. CZ will be the common reference for everyone. M1 is reference for the even side and M2 is reference for the odd side. Now what does the numbering and the alphabet means? C refers to the center line, F refers to the frontal lobe, and O refers to occipital lobe, and odd numbers are for the left side of the brain and even numbers are for the right side of the brain. Now how to go with the placement, I will show you one by one. So for these, for the placement of electrodes, we need few things. First is a measuring tape. Then we need a skin marker. You can use any permanent marker. This is a skin friendly paint marker. These are the cup electrodes which are used for the EEG capture. And to prep the skin for the electrode placement, first we need to clean the site with sterilium. Then skin is gently ablated with the new prep gel. And the third thing is the 1020 conductive paste. Now what is the significance of these all three? Sterilium we use to clean any oil, like any oil or dirt that might be present on the scalp. Our aim is to decrease the resistance as much as possible, because we are recording the activity of cortical neurons, and like there is skull, there is skin, there is head. So we tend to minimize the number of layers that can be minimized. So we can't remove the skin, we can't remove the skull, so we tend to remove as much as dead skin and oil or any debris that is possible. Now the function of the new prep gel is to gently abrade the skin, which it removes the dead skin. Sterilium is for oil removal, and the conductive paste, it acts as a medium in between the skull and the electrode. It is a small part of this paste is filled inside the electrode and then placed on the scalp. Am I audible to everyone? I would like most of the things have been explained to you by the faculty, like what is the mechanism of these belts, as you know, the induction resistance plethysmography. So I will be focusing more on the like what are the locations and how to place it. But if you want to ask like how this is recording, you're free to ask me. You can ask me anytime you feel any confusion. So for the electrode placement or EEG electrode placement, first we need four bony landmarks and 3 measurements. What are those 4 bony landmarks? First, we need the distance between the nasion and the enion. Nasion is where the skull meets with the nose, and enion is the occipital protuberance on the back of the scalp, of back of the head. And the other 2 bony landmarks are the preauricular points. Recorded the distances from here to here in between the 2 ears. These will be our 4 bony landmarks. And the third parameter which we need is the head circumference. Now how the head circumference is measured? We go from the glabella. Glabella is the this junction of the 2 eyebrows. We go from here, covering the enion, enion on the back of the head, and then we go this whole measurement we take. For nasion preauricular points, we put the measuring tape on one side and connect it to the other, and the nasion and enion in the similar way. So to make it easier and to consume less time, I have recorded the necessary measurements, these distances, and have done the necessary calculations beforehand. Now the first electrode that we place will be the CZ, which is a common reference, and we can move like it is according to the convenience of the technician or whoever is doing the study. But for like this is the thing, this is the you can say convention, or this is what we work according to. So the first electrode will be CZ. For CZ, what we need to do, we take the distance of nasion to enion. You can place put a vertical line here, and then the preauricular distance, and then again put a horizontal line. Now wherever these lines meet and form a cross, that point will be our CZ. So the CZ has been located now. Now we will move forward to the skin preparation for the electrode placement. First, we will clean the site with sterilium to remove any oily secretions from the scalp. The alcohol must be left to evaporate by itself, or you can remove some extra. Like ideal is to make it evaporate by itself, or you can remove some excess with a clear piece of cotton. The next step will be to take a very small amount of new prep gel and gently abrade the skin with a 2 and 4th motion. After doing both the steps, it is very crucial to make sure that the site is not having any residue of alcohol and nuprep, because these things can also aid in the resistance. So we will again clean the site with a piece of cotton. And now I will take a small amount of the 1020 paste on the cup electrode. This much amount is sufficient. Now how to lock the electrode in position? So you can we can use cotton, we can use any tape, or we can simply lock the electrode with the hairs. It's up to the convenience of the person who is recording how they prefer to go about it. So we are done with the placement of CZ. Now first I'll briefly explain how we'll go about the placement of other electrodes. So we have the 4 bony landmarks and 3 distances: the preauricular distance, nasion to inion, and the head circumference. Now we have located CZ and we have the and we place the electrode on it. Now you can see that C3 and C4 will be on the same line, and how much distance this is showing the percentage of distance which will be between the 2 points. Now you can see that C3 and C4 will be 20% of the preauricular distance on the either side, left and right of the CZ. On the left side we will find C3, on the right side we will find C4. This will be the C3 and C4. Now we have the head circumference. From the head circumference we will go we will again take, now we have inion. 10 centimeter above inion we will find the point OZ. How we will be of what distance this 10% is? The nasion to inion distance. So we take 10% and now we have OZ. Now we again put the tape on the head circumference, and of the head circumference we take 5 centimeter on either side, and we will find O1 and O2. Now comes the last 2 electrodes, which will be F3 and F4. How we go about it? From CZ we take 20% distance of nasion to inion, that will provide us with FZ. On the head circumference you locate F7 and F8, and then the midpoint of these two will be F3 and F4. Now this was the theory part. I will now show how we will proceed with it. So I have already noted the distance for the for our subject of today. The nasion to inion distance is 34 centimeter, preauricular is 39, and the head circumference is 69 centimeters. So as I told you earlier, we will now go for the C3 and C4. Again we will put the measuring tape, and the preauricular distance, it is 39, and we have to take 20% of 39 on both sides. That will come out 7.8 centimeter. From CZ we will go 7.8 centimeter left and right, and that will provide us the position of C3 and C4 electrodes. Again the same steps will be repeated for every site: cleaning with alcohol, abrasion with the new prep gel, and the conductive paste on the cup electrode, and then we will place it on the scalp. Does anyone have any confusion till now?
Applying electrode is so much time consuming.
Yes, the hookup part actually, ma'am,
Takes
it
so
takes
much time.
about, yeah, it takes about 1 hour. Like when a person is naive in it, it can take like initially it used to take us also like 1.5 hour, but with practice, like 30 to 40 minutes is minimum. Easy
And
placement is
removal of the electrode is the so easy process.
sorry, I can't hear you.
Removal of the electrode is so easy process. Easily
Yeah,
removed from
is
hair
indeed.
cell.
Am I audible to the participants? Dr. Hemlata, can you confirm if I'm audible?
Ma'am, volume is low. Your voice is audible, but your volume of so low. I can't hear you properly.
Okay, thank you, madam.
Volume is very low.
पीछे वाला गाना सर. And now, like most of the participants are online and you are having just a demonstration how to do it. If you want a hands-on experience, we have a techniques in medical sciences tips workshop every year in December. So you can register for that and come for a hands-on experience on polysomnography.
How, sir? How to apply?
Ma'am, it is, you can apply online on the website. The details on the AIIMS.edu it is. Tips has its own official website. You can Google it and you'll find the necessary details over there. The website will be live in July.
Okay.
And now now we will proceed with the electrodes O1 and O2. So we have located anion. How to locate anion? Like you gently you just feel uh, on the you go on the nape of the neck, and when you feel this protuberance, this point will be the anion. And now you go 10% above it, which is 10% of the nasion anion. It is 3.4 centimeters, and we will find OZ over there. So I have already located these 2 points. Now you place the measuring tape on the circumference and you go 5% distance of the circumference, which is 3.4 centimeter on either side, and you will find the positioning of O1 and O2. So O1, O2 is also done. Now the last two electrodes are F3 and F4. So now the placement of the recording electrodes is done. And when I was explaining the 1020 system, I told that which will be the reference electrode. So can anyone tell me again which were the reference electrodes? I hope I'm audible. So the CZ was our common reference. M1 I told earlier that it is the reference for the electrodes on the even side, and M2 will be the reference electrode for electrodes on the odd side. Now we will be placing M1 and M2. What is the position of M1 and M2? It's the bony protuberance behind the ear. You clean the site, abrade it the similar way which we have used for the head scalp electrodes, and then proceed with the placement.
That is the mastered process.
Yeah. It's the
Over
mastered
the
process.
mastered.
Yeah, over the mastered process. Shall I put the surgical tape on him also? The electrodes might fall down if I don't. Now I have placed M1 and M2. The last two for EEG will be one another reference and one ground on forehead. The reference we put on the glabella, and the ground electrode, it can be put anywhere on the forehead. Just close your eyes for a moment. For EUG electrode placement, the positioning is 1 centimeter out, 1 centimeter outside, and above and below for the from the outer canthus. By convention, we go 1 centimeter out and above for the right eye, and 1 centimeter out and below for the left eye. This is your right. This is left. coming to the last three electrodes, which will be put on the chin. For these are the EMG and will be put on the chin. So can anyone remember why we put EMG electrodes on chin? I'm expecting an answer.
Because of tone of muscle.
Yes, because in REM sleep, the muscle atonia, it is seen maximum, it has been shown that maximum muscle atonia occurs in the chin muscles. So the positioning will be 2 centimeter below the lower lip. Will be the we put three chin EMGs. Recording is done from one only. Two others are for backup. So the position will be 2 centimeter below the lower lip, and again we will go 2 centimeter down, left and right for the other two. So in total, chin EMG will consist of 3 electrodes. Can you pass me one electrode? Thank you. After the electrode placement is done, we need to plug in all the electrodes into the EEG head box. This is called an EEG head box, and as you can see, all the numberings, like where which electrode will go, is put shown in here, and there are the grooves where the electrodes will go in. Here you can see two are provided for the ECG. I will explain it later, just in few minutes. And these are the electrodes for chin EMG. 1, 2, and the third will go there. This is right now.
Hello.
Yes, yes, please.
Yes, sir. There are so many electrode now.
Mm-hmm.
P3 and P4. We did not apply all these electrode in this person.
Yes, yes. The the standard montage, which is like the sleep recording by ASM, it consists of 6 electrodes, 6 channel EEG we record F3 C3 O1, F4 C4 and O2. CZ M1 M2 and two other reference and ground are put on the forehead. These are so recording electrodes. We use 6 channel EEG.
Okay.
ये तुम होल्ड करके रखो इसको. The next parameter to be recorded in line is EEG. We record 2 channel EEG in polysomnography. Positioning will be positioning for the 2 electrodes will be on the right side subclavicular and on the left side on the mid axillary line, anterior mid axillary line below the chest. You want to put it? इसको लगा लो subclavicle. राइट साइड में. Anterior axillary line below the chest. ECG is also done. अभी ये पकड़ो. Effort belts. Now we will be putting the respiratory effort belts. We have 2 respiratory effort belts, one for the chest and one for the abdomen. Positioning for the chest respiratory effort belt is at the level of the nipples, and for the abdominal belt we go slightly above the umbilicus. This is abdomen.
Yes, so 2 recording of respiration, abdominal and thoracic, different.
Yes. For respiratory effort, these belts are required.
We get 2 recording different.
Yes,
one for thorax, one for abdomen.
Sorry, I couldn't. Can you please repeat?
We applied two belts. One
Yes.
for the thorax region and another is the abdominal region.
Yes,
So
yes.
we get in the recording in the computer, two recordings are there, only
Yes.
one recording.
No, no, no. Two are there. Two will be there when I show you the recording on the screen. I will explain what all parameters will be there. But yes, there are two different respiratory efforts we will see. One from the chest and one from the abdomen. टाइट तो नहीं है कोई ज़्यादा ठीक ठीक है ये हो गया इसके बाद and to detect any breathing abnormalities that basically associated with OSA and any other respiratory sleep disorder, we use a thermistor and a cannula for the pressure flow. Now this is a pre-sterilized thermistor that you can see. Thermistor will be first thermistor will be light. It will be worn by the subject. It will be below, and above it there will be a cannula. Okay, now you will be moving to the bed in a moment. ऐसा करो अभी तुम लेट जाओ इसके बाद में बाकी सब लगा दूंगा छोड़ दो इसको हाँ जस्ट एक मिनट रुको 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 ये मुझे पकड़ा दो इसको जाने दो इनकी दिक्कत नहीं है हाँ जस्ट सेट और अब लेट जाओ बस पीछे जाके थोड़ा नीचे हो ना या पिलो ऊपर करो परफेक्ट ओके
When we change the position of the patient, then the electrode, the chances of electrode removal are more. So
Yes,
what
yes, yes.
we do for this?
Yes, it is there. Like the electrodes come, they may come out several times during an overnight recording. So that's why the person who is recording, like ideally they should be awake for the entire night, but like waking up every hour or every once in every 2 hours just to check, that also works. So yeah, like continuous monitoring is required. That's why polysomnography is a very laborious process. So that was our EEG head box. This is called Somno screen. Now the EEG head box wire will be going inside, and all the other parameters, the this leg movement, sound, the flow which we have put, these the cannulas, etc. These will be going inside. I can show you beforehand. You might not be able to see it later very clearly. So this is SpO2. I will put a oxygen saturation probe on his finger. It will be connected here. EXG is the place where EEG head box will be connected. Flow, thermistor will be put here. In sound, we will place the snore sensor. In effort, the chest and respiratory effort, they are connected with each other with this connection, and now the common wire will be going in the effort section. Actigraphy, which we are not putting here, so this is not of interest right now. PLMR and PLML, these are the periodic leg movement electrodes, which I'll be putting in a few minutes. This press stands for pressure flow. The cannula will be connected here, and aux is for the body temperature, which we are not recording today. इलेक्ट्रोड कौन सा गिर गया ये तुम्हारा चिन से? लेग EMG के लिए जीन्स थोड़ी ऊपर हो जाएगी. अरे कोई नहीं, जितना जितना हो उतना कर लो. कोई नहीं, मैं जस्ट पोजीशन बता के इसको लगा दूंगा. These are our electrodes, recording electrodes for the leg EMG. The position of these will be on the belly of the anterior tibialis muscle, but as he's wearing a jeans, we can't like really put it on the real position. So I'll be just like, you know, the position, it will be somewhat like this is the shin here, here, and on the left leg it will be placed here on the belly of the anterior tibialis muscle. So now the hookup for the subject is completed. To summarize very quickly, what all parameters we are recording today: six channel EEG, EOG, EMG from two positions, chin EMG and leg EMG, respiratory effort from the chest and abdominal belts, two channel ECG, thermistor and cannula for the pressure flow, and yeah, that is all. Snow sensor.
What about blood pressure measurement?
Yeah, the ECG which is connected, we will take blood pressure when we are beginning the study, and the software has the software provides us a derived value of the blood pressure for the entire night. So we will record the blood pressure once, we will feed it into the system, and that will give us the derived value for the entire night. Huh? Huh. Uh, I have switched it on already. This is our snore sensor, which is a simple microphone to record any uh, snoring or any kind of sound that is made by the subject in a sleep study. It will be simply placed anywhere on the throat. Now, as the hookup is done, we will move into the recording room where we will do the biocalibration and show how a polysomnographic record looks like. No, ma'am, abhi nahi dala.
Both rooms are connected.
Shall I switch off the microphone, or it can be connected? I have noted his height, weight. Should we show them these things? Okay. Hmm. नेक्स्ट नहीं ओके करना होता है यहाँ से. Just just in a few minutes, we will be showing you the screen.
Hello.
So, is this screen visible to all of you? Someone please confirm that the screen is visible to you.
Yes, ma'am.
All right, great. So, what you can see here on the screen is the top two channels. Can you make out the top two green channels? These two? These are the eye movements. Okay. And since the subject is awake, they are moving up and down. So, it is showing a rapid eye movement. Is it visible from the screen, Rishabh?
Small in
Can the
size, ma'am.
Okay. And these, the next 6 channels, these are the EEG channels. And then this blue one that you see, this is the chin EMG channel. I'll adjust the gain a little bit. And this is the ECG. Can you just adjust the ECG? We'll just adjust the ECG. It's not coming accurately right now. Probably an electrode is out. Then this is the snore channel. This is the snore channel. He's not speaking, so there is no signal in this. Then this is the pressure snore. These are the flow channels. So one is the pressure, top one, and lower one is the thermistor. So they are showing the breathing pattern. So what we want to show you right now is biocalibration. So in this, this is the pulse which is there, then plethysmography, position is supine right now, and respiratory impedance plethysmography, rib, thorax and abdomen. So these are the thoracic movements and the abdominal movements. So we are going to show you, have you put the pulse oximeter? Okay, so now we will show you what we call as biocalibration. That means that for the channels for which we can change the stimulus, we will change it and we will check if it is working or not. Okay, so please pay attention. First of all, what I am going to do is, the ECG is all right now. If you can see, can you make out the ECG here? So we are getting a continuous ECG waveform. So now we will instruct the patient to move the eyes up and down and then left and right, and we will check if it is being reflected in the eye channels. So please move your eyes up and down. So this is showing up and down movement of the eyes. Please move your eyes left and right. So this is left and right movement of the eye. So you can see the signal is actually getting reflected onto the EEG also. So not that EEG is changing, but it is an artifact. It's producing an artifact in the EEG. That's why it is moving along with the EEG. Okay, stop. You can stop now. Please clench your teeth. Here. So you can see the tone of the chin EMG has suddenly increased, right? And this is producing an artifact in the EEG. So here you can see the clenching of teeth. All right, stop. Now please speak 1, 2, 3, 1, 2, 3. So we ask the person to speak so that we can check whether there is any signal in the snore. So when he is saying 1, 2, 3, you can see that the deflection is produced in the snore channel. So we know that the snore channel is working. Okay. Next, please take rapid and deep breaths. So you can see the rapid and deep breaths coming in the flow channel as well as the the thoracic and the abdominal belts. Okay, can you please hold your breath for 10 seconds? So here, I have asked him to hold the breath for 10 seconds so you can see apnea, which is there in the breath channels. Alright, you can resume breathing please. So this is known as biocalibration. And then we ask the person to also For example, in the leg EMG channels, we can ask them to move the foot up and down, and we can see whether the EMG is changing, so we can check those channels also. This is how we do biocalibration and we start the sleep study. And along with that, simultaneously, if you can make out, we also have the video here. So we are getting, for throughout the night, we are getting the video of the patient, and this is important for any abnormal movements that are there during sleep. And if we want to corroborate the findings of the sleep study with what has happened during the night, in that case we need the sleep to be recorded continuously, right? So any questions so far?
Ma'am, both room are connected with wire.
This is a wireless machine. It is connected by Bluetooth.
Okay.
So we have a Wi-Fi also here. So it is connected by the
Patient
Wi-Fi.
is in a different room and your recording room is different. So
Yes.
why I asked.
Yes, they are different. Can you just एक बार दिखा सकते हैं आप कि एक बार वो कमरे में जाके और फिर इधर आके, हाँ, we'll just show you. There is one patient room. We'll just take the camera to the patient room. So can you see that where we did the hookup?
Yes, ma'am.
This is the recording room, and now what you see, this is the recording room. That is, the people who are recording will be sitting in the recording room, which is outside the patient's room.
Okay, ma'am.
So
Connected with Bluetooth.
Yes.
Machine, our computer or our machine is connected with the wireless or with wire?
No, it is
Leads,
a wireless. It is completely wireless.
Okay, ma'am.
So the patient is free to move around. Patient can even go to the washroom.
Okay, ma'am.
So any other questions?
Ma'am, leg movement. Could you show me what changes occurs in the recording after patient moves the leg?
Yeah, I can. Let me see. We have the leg movement sensor here, but there is some problem with the sensor right now, so I won't be able to demonstrate the leg movement right now.
Okay, ma'am, no problem.
But it will come just like the EMG that you have seen. Let me show you that. When I asked the subject to speak, at that time you could see the change in the snore sensor, right?
Yes.
And on clenching
Yes,
the
ma'am.
teeth also you have seen this increase in the EMG. So similar
Yes,
increase
ma'am.
is seen when the legs are moved. Similar changes are seen.
Okay.
All right. So now I will show you some of the sleep studies that we have. I'll show you one normal, and I will also show you one OSA sleep study. I hope all of you have filled up the data in the Google Excel sheet.
Yes,
Is there
ma'am.
anybody who has not put in the data? Please let me know, because we have to submit it in the report.
I done, ma'am.
Yes, so am I audible now?
Yes, ma'am.
So I am going to terminate this recording now. This was an example recording for you. And we will show you our previous recordings. So the software is the Domino software. This is our Somnomedic system. We have two systems, sleep recording systems. We have the Philips system and we have the Somnomedic system. This is Somnomedics, and in the analysis, this is the Domino software in which we do the recording. So here we have all the sleep recordings that we have taken so far. So this is the sleep recording we have here. I'll show you in the middle where we have, this is the beginning of the study. Okay, the patient is awake here, we are putting the electrode. So you see some artifacts over here. These are some of the artifacts that you see when the patient is moving around. And if I show you the typical REM, then this patient was actually a patient of obstructive sleep apnea. And you can see the snoring here. Can you see these? Increase in the sound. This is the snore here. And this is the desaturation. The red, the software is already marked the desaturation. Okay, so this is a hypopnea. And this is the pink one is an arousal because there is increase in the EEG frequency. And here again this person has desaturation here. Okay, so this was a patient of obstructive sleep apnea actually. And you see so much disturbance in the REM part. So a lot of snoring is visible. Now let me see what the deep sleep looks like here. So you can see the high frequency, high amplitude waveforms. You can see the high amplitude waveforms over here. This is the N3 waves. Can you make out the high amplitude and low frequency? It's not visible?
Not clearly visible.
Okay, let's try to zoom. Is it better now?
Yes, ma'am.
Okay, I think we may have to call you for an in-person workshop. We will extend our invitation to you for the TIPS workshop in December. And also we conduct a national sleep medicine course and a sleep technology workshop which we conduct annually. So we will be doing it in September this year. Those of you who are interested, you can write to me on my email address. It is provided to you as the convener, and you can express your interest. We can invite you for that also. We are conducting it at AIIMS New Delhi this time. So here this is a typical REM episode. You can see the rapid eye movements here. This is an arousal and tone is very low. Okay, and the patient has snore, continuous snore is there, right? And this is an episode of hypoxia. The saturation is only 90% as of now. So here you can see saturation is fine. It is 98. Okay, and there is no snoring in the first half of the epoch. So this 30-second duration that we can see, this is known as one epoch. We can change the duration of the epoch also. We can make it 10 minutes. For seeing respiratory events, we look at a 10-minute epoch. Okay, so here you can see the respiration, you know how it is going. If we want to make out Cheyne-Stokes respiration, we look at a 10-minute epoch. Here you can see the snoring, right? EEG is always better visualized in a 30-second epoch. So this is N2. So in N2 I spoke to you about the spindles, right? So these are spindles, and since we have put in the settings, the software is already marking the spindles for us. So it makes life easy for us. We can easily make out that this is N2. Okay. I'm looking for a K complex so that I can show you a typical K complex. How many entries do we have in the Google Sheet? Okay. Sure. So this is also a spindle. It's marked as a spindle, even though it looks a bit like a K complex because there's a negative deflection and a positive deflection. I really can't make out if you can see on the screen. Are you able to make out the waveforms? Yes or no?
No. No, ma'am.
No. All right. Then I think we should conclude here. And if there are any questions, I'm happy to take those. So do you have any questions? We are going to conclude the workshop now. I hope it has been a good learning experience for you. I would say a good introduction to the topic, because it's really a very vast field, very interesting field, and there's so much. We take a 5-day course actually on polysomnography and on sleep medicine. So there is a lot to learn in that. So this is basically like a primer for you, where you can be aware that what is polysomnography, what are the basic parameters that are assessed during polysomnography, what are the indications, and how they are recorded, what are the principles of recording. So hopefully you have an idea about that. Yes?
Yes,
So
ma'am.
any
Yes,
of the
ma'am.
participants who want to give a feedback, or if you have any questions, you're most welcome. Even your feedback, if there is something which we could have done better, or there are some things which you appreciate, uh, the way they are conducted, it being an online workshop, so it does give an advantage to us that we don't have to travel, and no matter where you are in India, you can join us for the workshop. So that's an advantage, but the disadvantage is that you are not able to do hands-on, and sometimes, for example, when we were showing you the screen, you are not able to see the waveforms very nicely. If there is any feedback from your side, I'm happy to hear that, or any questions.
How much is the total duration for recording?
Usually we ask the subject to come around 8 or 9 p.m. Whatever, if their usual sleep time is say 10 o'clock, and then so by the time we finish the hookup, we take around 1 to 2 hours to finish the hookup and the electrode resistance, etc. We check that. Then they will wake up at their usual waking time, which is around 6 to 7 a.m. So that makes it 6 to 8 hours.
Okay. Thank you.
Any other questions?
Thank you, ma'am, for increasing my knowledge.
You're most welcome. It's our pleasure. Even if you have any further questions, you can email to us. You can write down at drnasreenakhtar@gmail.com. You can send me an email if you want resources to further study, or if you are interested in doing some research work. If you want to do short-term training, you are welcome to come to the lab and do a short-term training. You can learn polysomnography. You can do some short studies. So we have that kind of provision, which can be through the registrar of the institute, so that can be done. Any other feedback, any questions? So if you don't have any more questions, then from my side and from my team's side, I would like to thank all of you for joining us for these 4 hours. It is a pleasure for us to introduce you to our topic and to have people to learn about polysomnography and about sleep medicine. It's a very interesting topic, and I look forward to meeting you in some other workshop or at some other course, and look forward to interacting with you. Thank you. So we will now conclude this workshop.
Thank you, ma'am.
Thanks a lot.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.
Thank you.